Greetings, ladies and gentlemen. I'm Altaf Hussain, plastic surgeon working at the Cleft and Craniofacial Center at Chennai, India. I've been asked to speak about orthognathic surgery in children born with orofacial clefts. I thought I will broaden my scope a little bit more and speak about how to manage the midface hyperplasia in children with orofacial clefts. These are the pictures of children with clefts, and this is a child before the operation, and this is after lip repair. This is following palate repair as well. Now, what happens to them when they grow up? Midface hyperplasia, it's inevitable. It's an inevitable result of cleft lip repair. It's only the degree that varies. Maxillary retrusion starts very early in life, after the operation mostly, and progresses gradually to adulthood. So that's a child in the first few years, about 3 to 4 years old. The same girl in her teens, and this is her at the completion of growth. You can see the progressive retrusion of the midface. It looks nice and projected here. The maxilla started retruding in her early teens, and then it's quite severe and adulthood. So this is a child now, which we had done the lip revision when she was about 4 or 5 years old. She came to us with a badly repaired lip. We corrected her. She looked beautiful, and she also happens to be the poster girl for Smile Train, and her picture is on the wall of the Smile Train office in New York. Now, when she grows up, you expect her to be something like this. Nice, beautiful face, and however, this is what happened when she grew up. This was her in her just about when she was about to complete growth, about 16 years of age, and that was her midface. So this is just a profile outline to illustrate what we are talking about. You can see that the profile of the upper and lower face are normal. Her mandible is in normal position, and her forehead and orbits, and to an extent the bridge of the nose is normal. However, her midface is retruded. So we need to like that. We need to bring the midface forward so that they look good and they have normal function. That was her with reverse overjet and anterior open bite. And this is what we want. This is how we want her to be. And that is a lateral X-ray, lateral cephalogram. You can see that her midface is, the maxilla is retruded, and you can see the malocclusion with reverse overjet of her teeth. Now, this is what we want her to look like. The maxilla forward and posterior overjet. And so how do we manage this? You can kind of move the bones forward or backwards, depending on what you want to achieve. For instance, the primary problem is the maxilla, so it's logical to separate the maxilla from the rest of the skeleton. We call this the left foot 1 level. As you know, there is left foot 2 and 3, which are higher levels. Left foot 1 level is good for cleft. So we separate it at the left foot one level, and we can move this. You can see the arrow. You can move this forward. If that is insufficient, or if there is absolute prognathism, you can make an osteotomy at the to the mandible and set it back. But we can't make, because there is a nerve running through. If you would remember your anatomy, there is the inferior alveolar nerve which enters the mandible about there. You can see the shadow of the foramen, and then exits here at the mental foramen. So you need to preserve that. So one technique we use to achieve this is bilateral sagittal split osteotomy, BSSO in short. You can see that we can separate the tooth bearing and the condyle bearing parts of the mandible, preserving the nerve, and then we can move this segment backwards and forward. So these are the two basic techniques. Once you've made the osteotomy, you can rotate the segment, correct the cant, you can advance it or take it back as the case may be, and then fix it in the new position using plates and screws. The same thing you can do to the mandible as well. Now, when we do orthognathic surgery, just those movements may not be adequate. So it needs a little more tweaking. Sometimes when you plan the movements, it may require additional segmental osteotomies, which you can do. That's a anterior segmental osteotomy to the maxilla, and you can do a subapical osteotomy and move these segments separately and fix it to the rest of the skeleton using plates and screws. And you can also adjust the skin to balance. You can adjust the chin to balance the face. That's the chin segment, which you can move back and forth, and it's called genioplasty. Now, once you have achieved, you have made the osteotomy, either you can put the segments which you have divided from the divided into their new positions and fix them with plates and screws like you have done here. So this is him with a severe midface hypoplasia. That's an X-ray. And what you have done is we have done a left foot one level advancement, and you can see the plates and screws where we have fixed it. Similarly, we have done subapical osteotomy to the mandible, and we have fixed it with plate and screws. Or you have an alternative method. This is particularly important in a growing skeleton, in a child that's growing, or in older in younger children. You make the osteotomies. Instead of fixing them, you put in a distractor. This could be external, like in here, or it could be inside the mouth, what we call an internal distractor. That's an X-ray with the girl with the distractor, and you can slowly move the segment forward. It's called distraction osteogenesis. As you move the segments forward, it forms bone. So you could do that. And then of late, there is another technique that has gained popularity. It's again distraction osteogenesis, but instead of moving the entire left foot one segment like this, you increase the size of the maxilla. You can see the primary problem is the maxilla. So you make an osteotomy across the maxilla and increase the size of the maxilla. It increases the size of the alveolar arch, and when there is crowding of, it's ideal when there is crowding of teeth, because you can use the excess teeth to fill in the gap created by the distraction osteogenesis. This would be a better choice in many ways than the left foot one level osteotomy, because it addresses the primary problem, which means increasing the size of the maxilla. So how do you decide whether you want to, which operation? We have spoken about an array of operations available to us. We have different levels of osteotomies with fixation as part of orthognathic surgery. You have different levels of osteotomy with and distraction to achieve the the goal we want using distraction osteogenesis. We spoke about left foot one level and anterior maxillary distraction. How do you decide? This is a busy slide, so you don't need to concentrate too much on this at this point in time. All you need to know is if you are operating on the child before the child has is completed his or her growth, then it's better to do distraction osteogenesis. In an adult, since distraction osteogenesis takes time, it takes several weeks to achieve the movement. If it's an adult, you may do the same thing and fix it with plates and screws, and it's much less troublesome for the patient. So you need to first make a decision whether you want to do distraction osteogenesis or orthognathic surgery according to the requirements. The distraction, again, you need to decide whether it's left foot one, the entire left foot one segment, or anterior maxillary distraction. The reason I would choose anterior maxillary distraction is when there is crowding of teeth, so that we can utilize the teeth. If we are not going to increase the size of the maxilla with the anterior maxillary distraction, then the orthodontist can only align the crowded teeth by extracting some of them. So you save some of the teeth, and it also preserves the articulation and grinding surfaces of the teeth. However, it's a cumbersome process, takes time, and if you are an adult, you have the option of orthognathic surgery, where in one operation everything gets fixed. You just need residual orthodontics. Of course, you need pre-op orthodontics, which we'll go into, and then you need settling orthodontics. Now, you are confronted with a patient like this: severe midface hypoplasia. You have retruded midface. You may have problem with the teeth. You may have, like in this case, this child has not had an alveolar bone graft. The segments are in two parts. The maxilla is in two segments. Or there might be a neglected case where there is a lot of crowding of teeth and there are fistulae. So you need to identify the problem one by one and formulate a plan to treat them systematically. And then we'll just concentrate for now on correcting the skeletal correction of the midface. The planning is done in conjunction with the orthodontics, the surgeon and the orthodontist together. The orthodontist may use conventional cephalograms and use tracings to identify the problem and conduct a mock surgery to correct it. He also uses casts, and he or she may also use an articulator to transfer the occlusion to a model, and then he or she would again make a mock surgery to identify how much of movement of the actual jaw is needed, and then they give you a splint which can be used as a reference device to achieve the movement you want. So this is that's the traditional way, and that's a traditional splint which can act as a guide for your orthognathic surgery. Nowadays, you have several softwares. This is Dolphin, and without actually making models or cutting tracings from cephalograms, you can use a computer simulation to correct the skeletal deformity and even predict the changes that's going to make to the soft tissue. That is a computer-generated model pre and post mock surgery, and this is real real life X-rays. This is pre-orthognathic surgery, and that is post-orthognathic surgery. We can see that there are plates and screws that fix the maxilla, and then there are screws, the screws which you have used for fixing the mandible. We have used long bicortical screws to fix the mandible in this case. I shall illustrate what we were talking about in a series of cases, which we'll look into in a minute. So this girl is the one we already discussed. She had lip and palate repair when she was a baby, and she came to us when she was about 6 years old, when we had to revise her lip because it had been poorly done. Subsequently, she had an alveolar bone grafting when she was about 8-9 years old, and then when she grew up, this is how she looked like. She had a concave profile. She had class 3 malocclusion, reverse overjet, and anterior open bite. This was her cephalogram. Now we started with orthodontics. So the orthodontist not only plans, he is responsible for pre and post-op orthodontia. There are two ways of dealing with this. You have the traditional way where the orthodontist corrects all the dental decompensation, and then he plans for orthognathic surgery. However, that takes a lot of time, and the patients sometimes get frustrated because it makes them appear worse when they start the pre-op orthodontics. However, there is an alternative method which is gaining popularity. We are one of the earliest ones to adapt it. This is the surgery first. We do minimal pre-operative orthodontics, and then we do orthognathic surgery or distraction, and then do the rest of the dental correction, rest of the correction, including settling orthodontics after the surgery. So in her case, it was surgery first. She had fixed orthodontic appliance for leveling and aligning of the maxillary and mandibular arches before we took her up for surgery. The surgery plan was Lefort 1 osteotomy for the advancement of the maxilla, and a subapical osteotomy about at that level to correct the lower incisors. Postoperatively, settling orthodontics with reversible headgear for retention was planned. So she had a Lefort 1 osteotomy of the maxilla, and the advancement was 6 millimeters. And she had a cant which had to be corrected. So she had a 3 millimeter cant correction to the left-hand side. Her mandible she underwent a subapical osteotomy of the mandible, and we set back her subapical segment to the width of about 1 premolar. That is pre-op cephalogram, and that is post-op, how she looked. We can see the plates holding the subapical osteotomy segment. So her occlusion, this is her lateral view of the occlusion. She had reverse overjet and anterior open bite, which was corrected in the post-operative period. There is a slight addition to the requirement. This is to compensate for any relapse. We tend to overcorrect slightly in most patients so that even if there is some amount of relapse in the post-operative period, it gets compensated. So this was the pre-op occlusion, and this is the post-op after orthodontic settling. This is her frontal view, pre-op and post-op. So that is her profile before the operation. That is just after the first 24 to 48 hours after the operation. That was her at 1 year after the operation, and that was her 4 years down the line following surgery. So that is the frontal and again pre and post, and that is the bird's eye view. You can see that she still needs correction of her nose. She needs a rhinoplasty. So this is a girl with severe midface hyperplasia. So the reverse overjet was more than 12 millimeters. The plan in her case was left foot 1 level osteotomy and distraction osteogenesis, followed by postoperative orthodontics. So that was the lateral cephalogram pre. You can see the severely hypoplastic maxilla with a huge reverse overjet. So that was the picture taken when she was being. That's an extra. You can see the external frame. That's the level of the osteotomy. You can see the external frame. That is the traction wire which is connected to the osteotomized maxillary segment, which drags the osteotomized segment forward. And that is her in the postoperative period. Once the external frame and was removed and post-op orthodontics was completed. So that was her. You can see that's the occlusal view. I'm sorry, that's the view of the teeth. You can see that is the maxilla, which is severely retruded and with the severely rotated bite. You can see that that is the mandibular teeth, and that's the maxillary teeth. You can hardly see them. And this is her after distraction osteogenesis. Incidentally, when we do the distraction, we do the osteotomy and fix the device at the same time. We start distracting after about a latency period of 5 days. We move the segment about 1 millimeter in half millimeter turns. We do half millimeter in the morning and half millimeter in the evening to achieve about 1 millimeter a day. And we complete the movement. It takes to complete the movements, it takes about 20-25 days. And once that is the desired position of the maxilla is achieved, we retain the device for a few more months, and then even after the device is removed, we take measures for to prevent relapse. Now that was her pre-op. That was her at the end of distraction. You can see that she has been over distracted a little bit. That was her at 1 year, and that was her at 3 year post-op. So that was her profile pre and frontal photo pre and post. So we spoke about left foot 1 osteotomy. We spoke again about fixation as in orthognathic surgery and distraction osteogenesis of the left foot 1 segment. Now we'll speak about anterior maxillary distraction. As you know that this is, as you have already discussed, it's a relatively new technique. The advantage you get over the other techniques is it addresses the primary problem, which is the small maxilla and foreshortened maxillary arch, alveolar arch. So those are the osteotomies. We started the left foot 1 segment, but sharply make a turn downwards to end up between the premolars or the molar and the premolars. The osteotomy is extended across the palate to separate the segment, and then a device is put in to gradually distract this. We'll see the device in subsequent slides. we slowly move this osteotomized segment forward using the same principles as of distraction osteogenesis, which we already discussed, to achieve the target position. Now, this was a girl who had lip and palate repair, but when she grew up about 15 years of age, that's how she looked. You have a concave profile and you have reverse overjet. And a striking thing about her is the crowding of teeth. You can see that the she had been operated for the primary surgeries elsewhere, and she had been neglected till she was in her mid-teens when she came to us. So she had these very crowded teeth. Luckily, nobody had removed any to align it or otherwise. So we had all the teeth to work with. A small maxilla with crowding of teeth, which is ideal for anterior maxillary distraction. So that is intraoperative view. So we did the osteotomy, and this is when this photo was taken during the process of distraction. That is the distractor, which has been which takes support on the molars here and the premolars anteriorly. So these two teeth were together, as you can see here. This have been distracted. As the segment goes forward, it forms new bone. That is the principle of distraction osteogenesis. So you have a larger maxilla compared. You have this small maxilla with a very small alveolar arch. Now you have increased the size of the alveolar arch. However, the crowding of teeth persists, and the orthodontist moves these teeth gradually into the distractate, the newly formed alveolus, like so, and that is her. This is at the completion of orthodontic work, and that's a pre-op, and that is her post-op occlusion. And again, frontal view, pre and post. So now that is how she was, and we got her from there to here. This was after we revised her nose. We did a rhinoplasty on her subsequently. This is pre-distraction, anterior maxillary distraction, and pre-rhinoplasty, and this is post anterior maxillary distraction and rhinoplasty. Hopefully this is her. This is the face she would have had she not been born with the orofacial cleft. So we hope that we have successfully restored her to her original genetic face. So that is her pre-semi-profile view and post, pre-post, and that is her dental occlusion, post-op dental occlusion. So we were looking at the movements. We said when we do orthognathic surgery, we may address the maxilla, we may address the mandible, or both. So we just looked at about 100 consecutive cases. We found that majority of the patients either had just maxillary advancement or maxillary advancement and the sagittal split osteotomy to set back the mandible. Some of them had additional genioplasty, some of them had additional segmental osteotomies. Patients who had distraction mostly only had to have distraction of the maxilla. However, some of them had they were severely retruded, when some of them had to have sagittal split osteotomies to set back the mandible. Complication wise, there are the operation carries a fair amount of risk in terms of anesthesia. It's airway surgery, and it also involves osteotomizing bones. There are large vessels nearby, so you just need to be careful. Luckily, we have not had any major problems, but sometimes you have minor problems like gingival recession and regression. I mean, we also have relapse. So we take adequate precautions to prevent relapse. And when it comes to distraction, it's distraction osteogenesis at one point was notorious for its relapse rate, but we have a paper on it, and which is recently published, and we find that over distracting to about 20% seems to solve the problem. And then we also we need to use retention devices. If you just distract and leave it alone, it tends to again relapse. However, these operations, the distractions and orthognathic surgery are very rarely done in isolation. Since we are in a developing economy where there are lot of surgeons, some of them with different levels of commitment and skill operating on them, you get a lot of complications, and many of them come to us. So you have situations like these where you have multiple problems you need to sort out. So you have to do this systematically. This is a slide which shows the additional in addition to the 100 patients who had orthognathic surgery also had these operations. Some of them had to have their fistulas repaired. Some of the fistulas were so large as to require a tongue flap. Many of them needed surgery for velopharyngeal dysfunction. Nearly all of them needed lip nose. Several of them needed lip nose revisions. Many of them came to us without ABG, which had to be done before anything else could be achieved. So I'll illustrate that with one typical case. This girl came to us when she was about 24 years. She had had multiple operations in the past and had been given up. The problem she had was she had a poor lip and nose. She had a completely broken down soft palate. You can see that. She had severe VPD because of that. Her speech intelligibility was 5 out of 7. If 1 were normal and 7 were completely unintelligible, she was at 5. And she, of course, had severe midface retrusion, collapsed arch with a lot of missing teeth, severe malocclusion, and she had not had an alveolar bone graft. So we started with the broken down palate. So she had we repaired her palate. She needed a pharyngeal flap to get in some tissue because there was severe tissue loss there. She also had another fistula anteriorly. You can see that there's a big hole. We had to do a tongue flap. We had to bring in tissue from the tongue to close this. Following this, she underwent a distraction. This was pre and post-op. And since she was missing a lot of teeth, we had to give her a fixed partial denture. So this was her with her new denture. This was her pre-op, and this is her post-op intraoral views. So this was a profile pre, and this was during distraction osteogenesis, and this was immediately after distraction. You can see the overcorrection, and then this was her a few years down the line, and this was her after 4 years. You can see that the distraction has been stable. Now that was her pre. 1 year down the line, 4 years down the line, again, This was her worm's eye view pre, after rhinoplasty, and 4 years down the line following distraction of the midface and rhinoplasty. That's her profile. So she had several operations, about 6 operations spread over 4 years. She also had rhinoplasty, and she had extensive speech therapy, orthodontia, and prosthetic intervention. Her speech, which was 5 out of 7, which was very severe, improved to 2 out of 7, which is near normal, and very importantly, she could be understood very clearly on telephone. And when she when she communicates with others, this day and age, to be understood on telephone makes a whole lot of difference to your quality of life. Now that was her. She got married, and these are some of our patients. Thank you so much for your patient listening. If you have any questions, you can get in touch with us either when we have a video session for question and answers a few days down the line, or you can write to us at cleftcraniofacial@outlook.com. Thank you very much.